Okay, let's start so we can use the time that's devoted to that webinar. I'm Rémi Rabaza. I am a physician, endocrinologist, but I'm also what is called a clinician researcher, so a researcher that divides his time between clinical practice and research. I'm going to present you some data, some early data about the Better Registry and what we have been collecting in the last 2 years. So what is that registry? Since spring 2019, we invited people living in Quebec to respond to that registry, a kind of a census or large survey, and it's called Type 1 Better. Based on a lot of discussion with what is called patient partners, which are patients involved in research from the beginning, meaning from the questions that the researcher asks, and then they decide on how they will try to answer to that questions. Really the continuum of that registry is really hypoglycemia, low blood sugar. We really invite you to use the Q&A, really the Q&A. If you look to the top on your top or the bottom, it's not in the chat, it's really in the Q&A to have your questions, and I will try to do my best to answer most or ideally all of them at the end of this presentation. So I don't know if you're aware of this, but type 1 diabetes is not well known. It is frequently misunderstood and confused with type 2 diabetes. Actually, RCM, the research center in which I worked recently, made a Vox Pops in November, and the answers were absolutely astonishing. Most of the people of that non-scientific Vox Pop were actually completely confused between type 1 and type 2 diabetes. Another thing is that there is no good data, even in administrative database, allowing us to know how much people are living with type 1 diabetes in Quebec or even in Canada. So what is a registry? It is questionnaires mostly, or series of questionnaires that are completed online, and any patient living with type 1 diabetes 18 years or older is allowed to answer him or herself. The first part is 10 minutes, and roughly the second part is approximately 25 minutes, and the last part is around 40 minutes. So you're not obliged to answer to all parts. At the end of each part, you're offered either to continue at that time or another day, or to exit because you're just fed up. For parents of children of 13 years of age or less living with type 1 diabetes, it is a unique, smaller questionnaires, while for adults that have answered to the second and third of the 3 questionnaires, they are also invited to answer to an annual questionnaires, which we know is a bit too long, and we will reduce during 2022. In numbers, how much patients are now there? Close to 2,200, which divide in close to 2,000 over 14 years of age, and a bit less than 300 below 14 years of age. So that's the way it is divided. We estimate that it is probably approximately 1 patient on 10 living with type 1 diabetes in Quebec, though the exact number is so unknown and imprecise that it's only a very rough estimation. What about the numbers? What the patient tell us? Approximately 80% of the patient living with type 1 diabetes in that registry are actually, using a continuous glucose monitoring. 40% are using a pump. It's a bit more in kids because the accessibility of the pump and the governmental program is make the access to the pump easier in kids. No obligation to use a pump to control type 1 diabetes. 1 adult on 5 is treated and only covered by RAMQ. And the goal, the major goal of treatment of type 1 diabetes, which is HbA1c, which is that blood test that gave us the idea of the mean blood glucose control over the last 3 months, below 7%. It's a bit less than 1 on 3 in the adults. It is below 10% with the kids. 2 major points with this. Why we're looking to below 7% is because it reduced tremendously the risk to develop or to aggravate an existing complication. So either preventing from developing a complication, EI, having an eye complication, or preventing that eye early complication to become more severe. 30% could seem to you low numbers, but actually in most other countries, it's less than this. So it's far from ideal, but it's far better than else in most other countries where we can compare. And for kids, we must acknowledge that in quite a lot of situations, the kids, it could be a bit over 7%, could be acceptable for some kids. A bit less than 10% of the patients leave with a late onset, late form of type 1 diabetes. EI, not a form that appeared during the childhood or the puberty, or let's say, to keep it simple, below the age of 20. More and more in the last 20 years, we've seen more and more of those cases of delayed type 1 diabetes that can occur after the age of 30, at the age of 40, and even far later. And usually the entrance in the diabetes is a bit less intense than with the classical form that happen for the first time in the pediatric age. And so those people are frequently misdiagnosed as living with type 2 at the beginning, and there's a lot of confusion about the treatment, and usually they're only given the right diagnosis after only a few weeks, and sometimes months, and even sometimes a few times years. Let's speak about hypoglycemia, which the patient partners told us that it was really important. We will speak here we don't speak here about the values below 4, we will speak about below 3 and the most serious hypoglycemia, which are the one with loss of conscience. So 80%, close to 80% of the patient told us that they had at least one value below 3 in the last month. And among those 80%, 8 on 10 patients that tell us, the number of hypoglycemia everyone's were very close to 8 per month, so 2 per week. So it's a very high number, higher than some people tend to believe. And for example, this has a very practical implication. Below 3, usually patients have symptoms, unpleasant symptoms. They need to act. There is somehow some risk of getting to the next step, which is the severe hypoglycemia, the one that you wouldn't be able to treat without help. And it's a bit more than 1 patient on 10 that had that in the last year, which is a high number, very similar to what has been described in other countries. But the patient that had a severe hypoglycemia in the last year usually had an average of 2 episodes in the last year. Actually, one of the most important risk factors to make a severe hypoglycemia is to have presented in the last year already a severe hypoglycemia episode. So it's Beget, hypoglycemia, Beget, hypoglycemia, and even in those very severe forms. Another risk factors of getting those severe hypoglycemia is the patient that tend to have less symptoms when they are in hypoglycemia, what we call impaired awareness of hypoglycemia, where the symptoms are less and less important. Usually the patient love this. They told us, those unpleasant symptoms, they finally got away. But that's a way to have our internal alarm that it's getting low away. And then you can switch very rapidly from below 3 to a more severe hypoglycemia that can even lead to coma. So I'm going to show you some early data of that registry with close to 2,000 patients. Obviously, what I've done, because we made the analysis a few weeks, months ago, is not always on 2,000 patients, but all of them are on more than 1,000, and most of them are on 1,500 subjects approximately. So we're going to speak about consequences of hypoglycemia, about social inequalities and what is the risk of developing complications, about the discussion about do male and female patients living with type 1 diabetes are approaching hypoglycemia related to physical activity on the same way. What about low carb diet? This is extremely trendy. What are we seeing in the registry? And about stigma. Are people with diabetes stigmatized on a regular basis? So let's first look to hypoglycemia. What are those consequences? This is not trivial. It can be very important from day-to-day life, but which is very important for the patients, their family, and their relatives. but it's also important for some other aspects. For example, that tax credit that needs 14 hours. If the government considers that hypoglycemia is 5 minutes, that's it, that's all, it's very hard to go to the 14 hours. However, if a hypoglycemia would have in most patients a problem for, let's say, half an hour or even more, based on what I've just shown you, 8 per month, you already have 2 per week, and you already have 1 hour there, which is completely devoted to treatment and consequences of hypoglycemia. So even if it would be longer than half an hour, you would be already closer, despite the fact that we want to reduce hypoglycemia to those 14 hours for the tax credit. So what about the serious hypoglycemia below 3 and the severe that will need help? We're going to look this on the consequences of diabetes management, usage of healthcare services, and the daily life EI, the impact on, for example, physical and mental health. So we are going to contrast those two. First, let's start by diabetes management. Here, I should have my little, I lost it. Where is my little pointer? I apologize. I should have done that before. I don't see it. I will live without it. So a lot of patients, but not all, and this makes sense, after a low blood sugar below 3 will start to monitor their blood glucose more frequently. A third, also a bit less than a third, and the previous one was a bit more than a third, say no consequences, maybe because they know what happened. They were about to eat, they made the injection, it's a young father or mother, something happens with the kids, and then you had your low blood sugar because your meal was delayed. This was completely unplanned. You had to deal with an unplanned situation at home. That can happen. You just know what happened, and you try to minimize those things. A bit less than a third would adjust one insulin, makes sense. You had repeatedly low blood sugar below 3 at night on a repeated basis. You need to reduce your basal insulin that covered the night. Something that is probably less desirable on the long term, at least, is to start to consume more carbohydrate. Maybe because some patients would hesitate on what insulin to adapt, or maybe because they tried it and it doesn't work. What about more serious hypoglycemia, the one where you absolutely need the help of a third party, which would include a coma? You can see that the number of patients that would monitor their blood glucose have jumped from 39 to 55%, which makes sense. 34% rather than 27% would carry carbohydrate at all time. Really, that number should be 100%, or at least 99.9%. When living with type 1 diabetes, having simple carbohydrate close to your hands at all time is probably a very normal, safe behavior that I would strongly recommend, even if it's not pleasant to hear this. And a bit less than a third, or a bit more than 1 on 4 are actually adjusting their insulin dose on a regular basis. And again, a bit more than 1 on 4 are consuming more carbohydrates. So this really drives on the fact that us as healthcare professionals should help patients to try to use carbohydrate not as a preventive measures to reduce hypoglycemia unless very specific circumstances like unplanned physical exercise, but rather to say, let's discuss about what insulin we should adjust to minimize those hypoglycemia, either serious or severe. Uses of healthcare services, 8 patients on 10 with levels below 3 don't discuss this, or won't, it's not true what I'm telling, will not request an earlier appointment because of this. Only 16% of them would discuss such level below 3 at their medical appointment. It's a bit disappointing from my point of view, but I can understand. There's a lot of things to deal during an appointment. And as I showed earlier, it's so frequent that maybe the patient knows or learned to live with it. Severe hypoglycemia, only 40% discussing it at the medical appointment. This is far too low. There are a lot of things to be done to prevent that patient that did a severe hypoglycemia to be at high risk of a recurrent episode of severe hypoglycemia, and it should be discussed. We will discuss this. Some patients don't really feel, they really feel bad of having a hypoglycemia. They're afraid of the consequences, for example, losing the driving license but I really believe we should be here close to 100%. 40% no consequences. This is really strange and show that us as healthcare professionals, we should systematically ask the patient, discuss this. And you can see here that approximately a third of the patients with a severe hypoglycemia needed the visit of the paramedic, and nearly all of them that had the visit of the paramedic went into the ambulance. What about the physical and mental health consequences? This has not been well studied in the literature. Below 3, a lot of patients, close to 60%, tell us no big deal, but a bit more than 1 in 4 tell us persistent fatigue. And when you look in the details of the question, they don't tell us persistent fatigue for 15 minutes. They say for hours after an episode. Imagine a patient that would have this and that have those 8 episodes per month that I told you around this. So it's really important. A bit less than 1 in 5 develop anxiety, which you can see a fear of hypoglycemia. And you can see that number really jumps to close to 40% after a severe episode. A third, no consequences. That's a bit surprising to me again. And a third with persistent fatigue, which can last for days, as some patients describe. And a bit less than a third of them, or a bit more than 1 in 4 of them, are feeling that they are feeling shame. They blame themselves around this, which I've seen frequently, but frankly, even after years and years taking care of patients like this, I don't really understand why it should be. It is a traumatic experience. Don't blame yourself for that. We need to discuss and to try to do what to do to minimize the risk of recurrence of those episodes. So overall, hypoglycemia have huge aspects on people, on life of people living with type 1 diabetes, and it cannot be as people in the evaluating the tax credit form or some healthcare professionals say, oh, no big deal, it's only 5 minutes and not happen so much. It just happens when you don't do things correctly. This is not true, and the consequences of hypoglycemia are largely underestimated beyond the community of people living with type 1 diabetes. By the way, when we look on the scales of the importance that is given to those things, women tend to report more consequences than men. And it's probably not that hypoglycemia has more consequences or is more frequent or more important in women. It is probably far more that women express better or more their concerns about hypoglycemia than men should do it. And this is an analysis that is ongoing with us. It's a registry. We look to what people, it's not always easy to make a line between a symptom or a fact and the causal effect, but we will try to see what we can do with the data we have. Let's move to the next analysis that we've done. What definition choose for severe hypoglycemia? So for those episodes with the need of a third person. So we gathered together a lot of what those patients that we call patient partners, those patients that tell us they want to be engaged in research. They help us to say what domain we should look at and how we should look at. And then I try to make the music with the notes they give me if I can try to translate badly a French-speaking expression. So they came with us and they said, you know what, those definitions you're using, and I'm going to make there, you professional, that it's something needing an assistant from another person, using glucagon, being hospitalized, loss of conscience, and there is also an additional sentence that we should say that is leading to neurocognitive dysfunction. First, this is wrong, they told us. And they told us that it's wrong because, for example, you're at home, you're living with type 1, you're on the sofa, you feel you're a bit low, you have your partner, which is not so far, and you tell her, please bring me a glass of juice or my Dex4 pills or whatever. This is just normal life. The partner is helping, or the parents with the kids and so on. But by the medical definition, this has become a severe hypoglycemia. And if you go to legal implication, have an important implication. That sentence that we just didn't put because it was too long about neurocognitive dysfunction. Those patient partners told us that just look like dementia. We're not having dementia. We're just a bit less bright at the time of a very profound hypoglycemia. So they came to us and we gathered them all together. This was pre-COVID, and we were able to discuss, and they came with a very simple sentence. They said, a severe hypoglycemia, it's an episode that I would never have been able to treat myself. So please don't count when my partner is bringing me my glass of juice just to be nice with me and to allow me to just go and look to the ongoing film, and I'm going to see this. So they came with that very simple sentence, and any patient in the registry then answered to the long, complex medical definition or to the simplified patient definition. So you've seen this already in the previous thing, that one. So the blue bars are the medical complex definition, and the black bars are the simplified definition by the patient. So two things we're going to see here. First thing, when you look to you go from the overall, and then we break those data between the patient that feel their symptoms of hypoglycemia close to the 4 here. If you can see my mouse, to the right-hand side, where they literally have very few symptoms of hypoglycemia, unless they would be very close to 2. You can see that the frequency of severe hypoglycemia drastically increased and go to up 41% of the patients. The second thing is that the blue bar and the black bars are not exactly the same, but they follow exactly the same trend, exactly the same impression and validity around those things. And as the patient told us, you're going to find slightly less hypoglycemia with our definition, because obviously when you count that my partner is just bringing me to be nice a glass of juice, that's not true. So actually the conclusion of that work, and we have submitted this, and it's going to go what we call peer review. So other researchers are going to criticize our job, and they don't take the good thing to say us it's a good study. They only tell us what they don't like, is that keep it simple is important. If we can have something that we all together understand, which is a smaller sentence and better understood by everyone, let's keep it this way and take away the few episodes that are probably not real severe hypoglycemia. What about now socioeconomic status? If you are not well deserved by life, if you have lower income, if you have less coverage of your insurance, would it be that maybe even in the Quebec system, which is one of the most universal, the most generous in North America, not perfect, but probably better than what can be seen south of the border, what happens? So for example, in the US, if you're poor, unemployed, or without private insurance, the risk to develop diabetes complication, the eye, the kidney, the nerves, the heart, are tremendously higher than if you have private insurance, better income, and so on. So what happened in a system like ours, which is far from perfect, but with less inequities? So here you're going to see the percentage of patients reporting at least one complication based on various factors that are the ones that are using by people in social science to try to capture people that are less lucky in life, less deserved by life, and have a lower income or lower access to money or to services. So people that have a private insurance in that survey, approximately 1 in 3 are describing of having at least one complication in the eye or the kidney or the nerves or the heart. Where people that have AMQ, the public system, which is one of the best in North America in terms of what we access to, it's actually far more, 50% is really higher than 34%. What about employment? Usually when you have a full-time job, you have a better income than when you are unemployed. So when you have a full-time job, it's a third. When you have a part-time job, it's a bit less, but there was a lot here of people that were close to the retirement, people that were working part-time because they are decelerating their active lifestyle. But when you are unemployed, when you are au chômage, as we say in French, you are jumping now to 1 in 2. What about level of education? Usually when you have more diplomas, usually, not always, but it translates as a mean in a better income. So where you have post-secondary education, it's a bit more than a third of the patient that describe at least one complication. Where we have less than high school it's at 1 and 2. And what about revenues now? If someone have over 100K per year, $100,000 per year, it's a bit less than a third. If you go 60 to 100,000, it's 40%. If you go lower, 30 to 60%, it rises to 45%. But if you are really below $30,000, and it's not easy to live in Quebec with less than $30,000 per year, it is now 1 and 2. So despite the fact that we do have, and RAMQ have a lot of problems with it, but it's one of the most generous system in North America, we can still see, despite that system, it is far less pronounced than in the US, but we can really see here that underserved people, the people that have lower socioeconomic status, and no one chooses to have this, still have a higher risk of complication, and that we have things to improve. So I am for Diabète Quebec, the head of the professional section, and we will take those numbers to the government to show how much probable access to care, ability to be able to implement care related to poverty or to some aspect of poverty can still kind of impede your health more than if you would be more lucky, more rich, more being able to adhere more easily to a healthier lifestyle. Let's move to another question now. Are men and women approaching the two key ways to reduce the risk of hypoglycemia during physical activity? I mean here, reducing the dose of insulin in a preventive fashion, in anticipating that exercise is coming, or taking more carbohydrate, which can still be needed when insulin is reduced by anticipation, but which is generally absolutely mandatory in most cases when exercise have not been planned. So do men and women approach this in the same way? Oh, I have a little animation problem here, but we will correct this on the way. So approximately 2/3 of the women would monitor their blood sugar more rapidly, and it's the same for men. Approximately 62% of the women would eat more carbohydrate. This is definitely the most used way because it covers when you have reduced your insulin, but it's not sufficient, plus the time where you didn't want or didn't have time or didn't plan your physical activity, so were unable to reduce your insulin at the time it was possible. And you see that the men, 62 versus 71 in an approach, in a strategy that close to 10% difference is really important. So the men are using more snacking to prevent hypoglycemia than women in a context where everyone is using this. What about carbohydrate for hypoglycemia after physical activity? It can also occur after physical activity. Again, men use this more frequently than women. And now let's speak about insulin dose reduction. 57% of women reduce their insulin dose and 55% of the men reduce their insulin dose. So the take-home message we have from this, and actually it was just accepted for publication in the last 24 hours in the most prestigious journal for diabetes, a bit like kind of the New York Times of the diabetes field, is that male and female don't really approach hypoglycemia prevention in the same way, in the sense that male rely more frequently on snacking than women, which probably indirectly indicate that women need more information about how to manipulate their insulin, and they are doing it in the same fashion, but they probably want to know a bit more about this. Let's move to the next subject. It's not the last one. We still have the low carb and the stigma. What about low carb diet? This is trendy. This is à la mode. This is really fashionable. It's really important. So what happened here? We did on a very, very large number of the patients that in the registry in the first phase told us how they were eating. We classified people from the one that were eating the most sugar, the group 4, with not so much fat and not so much proteins, to the one at the other extreme having 4 equal number of groups. So let's say that you would have 100 patients, we would make 4 groups of 25 patients with this. So the other extreme would be the one that eat less carbohydrate, but rather more fat and more proteins. And obviously at the middle, it's in between. This was done on hundreds and hundreds of patients that gave us to do. So what does it really represent? Actually, you're going to a bit more than 271 grams of carbohydrate per day. It's a bit different between male and female, men and women, but I haven't put it here, the difference just for the simplicity of the number, 267 grams. This is not the famous keto diet. This is just being on the low side of carbohydrate intake. So there are people who are just taking care to eat a bit less carbohydrate than the mean patients. So what happened? What is your likelihood of reaching the goal of a A1C below 7%? It's a bit less than a third in the group consuming the more carbohydrate, and it jumps nearly by twice when you are consuming less carbohydrate, but not going to the keto important diet. So just reducing your carbohydrate is associated. We cannot drive consequences between that habit and the result. We only see an association. It suggests that there is a relationship. It does not prove it at all. What about hypoglycemia? Maybe you're closer to the goal, but maybe you're making more hypoglycemia. So what happened here is that we see exactly the same frequency of those serious hypoglycemia, the one below 3 per month. You can see that the frequency, the number is exactly the same. There's no trend for more hypoglycemia when you at least eat a bit less of carbohydrate than the mean patients. And we had on the large subgroup the bad cholesterol, and we were able to see that the goal for most patients living with type 1 is to be below 2. We were seeing it was a bit high, but there is no obvious trend, unfavorable trend. So what we can say here is that there's a higher likelihood of achieving an A1C at the target when you're eating less carbohydrate. Not sure that it's a direct causal effect, but it makes sense. That study cannot prove the direct causal effect, but it suggests no further hypoglycemia. What we've shown you on the bad cholesterol does not prove that it's cardiovascular safe. And this was asked in the Francophone version that I've just presented before you. Those diets also leading to eat a bit more protein. Very, 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 very high intake of protein can be bad of the kidney. Is there is any sign for the bad adverse event on the kidney? The answer is this was not measured in that study. We don't believe at those level of carbohydrate and protein, there should be any adverse effect on the kidney. Let's move to the last section before we would take time to discuss those results, what it means for you and any additional question you would have. What about stigma? Are people living with type 1 stigmatized? So my colleague Anne-Sophie Brazeau, which is co-leading that study with me, is having one publication nearly accepted where she's actually showing that the picture in the media, in film, series, in the theater about people living type 1 is just like handicapped people, always making big loads and needing people. So this is stigmatization. When people in the cinema and in the literature are always showing people living with type 1, like people having a recurrent hypoglycemia and malaise, that is a stigma. So we asked a lot of questions about stigma in the registry, and we had heartbreaking response that I'm going to try to summarize. And because the results are quite different in teenagers, 14 to 18, up to adults, we will segregate this in 3 categories. And you'll see that the podium, the 3 most frequent, are not only extremely frequent, but frequently the same at whatever age. It's more around the frequency that it changes. So 9 on 10 of the teenagers are badly judged if they would eat a soft drink, for example, or a candy. 8 on 10 hear unfair assumptions around the fact that things that they can do because they are diabetic. Oh, you can go swimming because you are diabetic, or you cannot have a dessert because you are diabetic. And 8 on 10 are blame, or they have the feeling that the others look them as irresponsible persons where the blood management is not perfect. As someone at the Ministry of Health told me a few years ago, if those patients would do all you advised them, Dr. Abaza, everything would be perfect. I can tell you this is not true, as you already know. Let's look now to young adults, 20 to 25 roughly. Again, 83% of them receive unfair assumption. 80% of them feel judged when they would eat something with a bit of sugar. And close to 80% of them are really feeling embarrassed when they need to manage their diabetes in public. For example, inject an insulin dose with an insulin pen or manage their pump. Let's look to adults now after 24 years of age. You can see again, 8 on 10 feel judged if they don't eat foods with sugar contents, obvious one. 64% of them are looked as irresponsible if their blood glucose management is not perfect, and 62% of them feel assumption. Roughly, it's nearly always the same stigmatization, but you can see that older you are, it remains extremely prevalent, but it's a bit less when that you are younger. So judgment about glucose management and living with type 1 diabetes lead to a lot of stigmatization, and we see this even in healthcare system. Oh, that patient, he came to emergency because she is not able to manage his diabetes. Come on. The age plays a role, and roughly the younger you are, the worse it is. But even if you are older, it remains extremely prevalent and definitely, I guess, extremely unpleasant for the patient. We haven't shown you to that, but people that have a bad glucose control usually perceive more stigma, probably because they feel more guilty and they feel more unpleasant of not reaching the goal, the graal of the A1C below 7%. So let's finish on a few facts. If you are listening to us tonight or on YouTube, if you're not yet on the registry, we would say to you, you have more than 4 reasons, but we are going to limit ourselves to 4 reasons. We really want to have the best picture as possible of type 1 diabetes at Quebec. It helps us for advocacy. It helps us for researcher. It helps us to change the landscape, even for healthcare professionals, to help them to give better care. The second thing is that we have well-attended webinars. We are really careful to give most or nearly all what we do in a bilingual fashion. And we fully acknowledge that giving the information in mother tongue, even if this is not my mother tongue, I hope you're able to understand me, is important. We give quite a lot of Amazon 500 gift cards. We have each number of patients we choose, we buy by chance a patient and give an Amazon gift card. And we have just validated the support platform, which is an online self-training platform specific for type 1 diabetes that allow the patient by little blocks of 6 to 10 minutes to make their training to what is really important for them on diabetes. We've just finished the validation about the safety and the efficacy of that platform. We will make this far more larger available next year. The link to our registry is in the comments, and we are extremely grateful to the time you give to us. You are a healthcare professional and listening to us, you can also have material that would help patients to be referred to the site. All of this is very largely paid by governments and the GDRF, the Type 1 Diabetes Foundation. We had small gifts from industry, which represent far less than 10% of the overall budget. We are now going to move to the question and answer. Please use as much as possible the Q&R and not the chat to ask the question. It really helped me to answer far better and more in a more exhaustive fashion to all the answers. And I just want to answer that in January, the webinar will be on youth and adolescents living with type 1 diabetes, and it will be with Dr. Melanie Anderson from St. Justine Hospital and Janie Bédard from the Caruanis diabetes camp. And in February, we will have Andréane Fortin, nutritionist, and Roxane Saint-Amand, kinesiologic, which will speak about losing weight and diabetes. Those slides were prepared by Sarah Ag, which is an absolutely outstanding way to translate in a simple, and I hope you will agree with me, a nice fashion that Dada and Myriam Talbot helped us to minimize the risk of errors that us Francophone can do when we try to speak in English. So I will now move to the question, and I will use mostly, and then I will try to see if in the chat there are questions, but please use the Q&A. And I haven't had a few questions that already Francophone patients asked us recently. So I'm going to read them and to try to answer to them. How come the A1C, so that blood test, is still considered as the gold standard and not target and range? A1C can be most misleading. For example, it doesn't count hypoglycemia. So the question on this is that time in range is becoming now the gold standard, but A1C gives, I would say time in range give us the idea of the quality of A1C. Time in range is more and more, and it's going to become the gold standard. It has now been related to the risk of complications. And yes, it do integrate the hypoglycemia. And you can have the same A1C with few glucose fluctuations, which is probably far better than the same A1C with wide glucose fluctuations. So we will probably move in upcoming years for people living with type 1 as time in range as the new gold standard. But there is still ongoing discussion about the fact, that if the classical time in range, which is around 14 days, should be then used around 90 days, for example, as the measures for the risk of long-term complications. So the 14 days would be more to adjust your therapy. The 90 days would be more an equivalent of the A1C. So someone telling us, I exercise almost every day to maintain my good health and help to control my blood sugar. There is an average, this is an average of 4 hours per week, 4 hours per week. Can I use that for my tax credit, my credit tax? The answer at this point is no. As the head of the professional section of Diabète Quebec, which my role as a physician is to be the spokesperson of the patient. I'm not alone now. We've changed things since I came to Diabète Quebec. We have a patient group representative, so you can go on the website of Diabète Quebec, found who of those people went around. Some of them are Anglophone and speaking, and we are now going to the ministry to ask this to be changed. The election, the federal election, delayed some new criteria that would be added, but as far as I remember, I'm not 100% sure the exercise cannot be counted in the 14 hours of this. I could, it's quite easy when you count all the things you have to do with diabetes to count this, but the problem is that the tax credit people don't count everything. They have decided that this is not and this is not, but new things will come in that count in the next year. They have not yet been published to know who they are. Getting to those 40 hours can be done quite easily. The list of things that are acceptable will expand, but it's that those expansions are not yet public and have not been released by the federal government. What is the impact of social inequities on diabetes management? They are huge. Sometimes, for example, even if in Quebec, we have one of the most generous systems in North America in terms of medication and care access, there's still a little part that is paid by the patient. So you can imagine that at the end of the month, you're losing money. You might delay of a few days going back to the pharmacy. And because you don't want to run out of insulin, you're going to underdose your insulin and then have hyperglycemia. This will lead to complications. So people that are less, I'm missing the good words in English here, but that the life did not serve as well, usually have numerous reasons. So we see a less of an impact in our public health system than in the US, but we still see an impact. As I showed you, roughly any big social inequity measure that the government is using is leading people from the mean third of the complication having at least one complication to 50% of them. The other thing, what do I recommend about the feeling about people judged by other non-diabetics? I don't know if I can recommend something, but we need to get out, to get the voice that people living with type 1 are not handicapped person. I would say that when we had Max Domi here, it was wonderful. You know, hockey is one of the Quebec most important religion. We need people that are spokesperson. We need to change things progressively. So for example, my colleague Anne-Sophie Brazeau, she's going to use the work she said. She really literally went on series and movies and theaters to see how people living with type 1, when they are in those popular things are presented. And it's completely dramatic. So we want them to go to La Guilde des Acteurs du Québec, you know, those associations, say, hey, come, you are making efforts to have a better diversity and representation with more people, colored people, with more women and so on. By the way you treat diabetics or you present them is going to change. So I don't have good things, but we need to be vocal. We need to state this again and again. What about racialized individuals? I must say that despite all our efforts in the registry, the better registry currently, it is more than 90% of people that are described as Caucasian ascendants, so white people originating from Europe. We want to have more racialized people. We are trying our best to get them. If you have any idea that how we could improve on this, please discuss with Sarah, which is online tonight. We will make all efforts to improve this, but obviously we cannot say a lot about those people because the percentage in the registry remain far too small. This is not our will. We want to change this. We are struggling to get, I must say, more racialized people, and I'm happy to see that we are having some Anglophone people here. The representation of Anglophone people is below the percentage of the Anglophone people in the Quebec population. We want to improve this. What about some MODY diabetes? Those are mature onset diabetes of the youth. So those are a rare form of far closer to type 1 diabetes. And they are what some people are also speaking about double diabetes. Double diabetes is people living with type 1, but that do have frequent features of type 2 diabetes. For example, they would be living with type 1, but have obesity. They would have higher doses of insulin and so on. And we do have some ongoing analysis of double diabetes in the registry. We won't have about MODY or MODY 3. There is 1, 2, 3, 4, 5. There's rare form of diabetes, which are outside of the scope of the registry. Usually maturity onset of diabetes, it's only one gene. We know what it is. And we usually have specific treatment for those patients. Do you think that more primary physicians should check fasting glucagon levels in patients with type 1 and type 2? There are no practical, we do this in the lab. We do a lot of studies, for example, around prevention of hypoglycemia during physical activity. We measure glucagon in the lab, just what you see behind me. There is no practical implications to do this. I will not take any different decision. I know this has become fashion in the US, and because some people would tend to have low glucagon level and are maybe more exposed to hypoglycemia, and people have high level of glucagon, and we have some medication that would reduce this. Frankly, there is no good evidence that it can be done, and glucagon is not readily available in Quebec. And glucagon dosage in Maisonneuve-Rosemont versus the CUSUM, the McGill Hospital, is not normalized, so you can have a threefold difference between the two. So roughly, it is one of those fashions that have started in the US. At this point, I give you a personal opinion. I don't believe it should be done because it would not drive any real practical implication for the patients. Not related to hypoglycemia, but by me being immunocompromised, type 1, am I immunocompromised? So yes, type 1 is a disease of autoimmunity. So this part of the word is the same, but it's immunity that gains against you. It's different from being immunocompromised. For example, you had a kidney graft and you have an anti-rejection medication, and then you're immunocompromised. So it's similar words, but completely different meaning. One, your immune system was too strong and it destroyed your beta cell. The other one, your immune system is down, either because you have a disease or because we give you medications for this. I must say, however, that people that with type 1 diabetes that have very high level of glucose, the mean A1C over 9%, have some degree of lower immunity. And is this related to severe COVID? If I can make a very rapid one-on-one courses on severe COVID and immunity, is living with type 1 exposing you to get infected more frequently by COVID than someone not living with type 1? The answer is no. There is no increased risk of being infected with COVID. If living with type 1 exposed you to have a more severe form of COVID, so for example, needed to go to the emergency, being hospitalized, and even worse, going to the intensive care unit, the answer is yes, but only for a fraction of the patients. The patients that have that risk are the older ones, exactly like in the general population. If you're living 75 with type 1 diabetes, you have the well-described risk of people living with 75, even with type 1, more directly related to type 1 diabetes. If your A1C, the mean blood glucose, is over 9%, it seems that it increased the risk. If you have kidney dysfunction, not a mild little kidney problem, but the one where your doctor already told you that it filtrates less, if you already had a heart attack or cardiovascular complication at large, then you have more risk. So it's more related to age, as in the general population, probably higher a severe form of COVID when you have really bad glucose control. And it has been shown that if you improve your glucose control, you reduce the risk of having a more severe form of COVID. And the people that have quite significant complication of diabetes, so it's not everyone. If you're less than 40, if you're well controlled, no complications. And after 40, it's a mild and increase. And we can see it increase in the general population. And then with type 1, it increased a bit more at any age. I hope I was able to summarize a lot of research. To give you an information, Health Canada asked me to summarize the literature and to present to their bureau around this. So there is kind of a sensitivity in Health Canada that at least they didn't knew how to divide type 1 and type 2 diabetes. And to finish on COVID, there is no increased risk of developing type 1 diabetes if you've been infected at the COVID. All the numbers have been looking. However, what we've seen is that people that have new onset type 1, they don't know exactly what happened. They know it's not going well. They have a lot of thirst, they are avoiding a lot, they are losing weight, they are hungry despite of this, and so on. They came too late. They came later. You know, all those rules that we had at the previous rate. And I apologize tonight that the Prime Minister Legault just said all those bad news to us. What about COVID and type 2? There seems to be a relationship in the risk of developing type 2 diabetes with COVID, but not with type 1, rather than going too late or later to the hospital. And we can understand why is this. We need a wide information about type 1. I had no idea about my son diagnosed at the age of 17. This is something with Thing at Diabète Quebec, and I'm really working, you know, there's those 3 big organizations, Diabète Quebec for Quebec, Diabetes Canada for the rest of Canada, and the GDRF for type 1 diabetes. I'm really working very hard to have everyone working in the same direction. And yes, we need to have something at the Super Bowl, not Max Domi only telling I have a G6 and this is wonderful, but to tell people here is diabetes. Stop to stigmatize. Those people are not becoming diabetic because they ate too much candy. And the last Halloween, I fully agree that we need to be on that market of knowing, a bit like people with cancer did. We need to take example on this. Does the age of diagnosis make a difference in the management of the disease? The short answer is yes. We are working on this. We are currently contrasting the people that develop diabetes later in life with earlier in life. We will come back in a future webinar on this. It's my young colleague, Dr. Nadine Taleb. As you see, I am missing hair on my head and I have a white beer. We are having tremendous young people like this, and that's another goal of that registry, to attract young doctors and make them interested. But yeah, there are issues: when to start a medication to protect the heart, when to start a medication to protect the kidney, are some of those things. And yes, those people developing diabetes in the later age sometimes can benefit of treatment of type 2 diabetes in some other circumstances. I don't know if you could answer to my question, but do you recommend the third dose of COVID vaccine when it's coming? At this point, based on science and based on what we know, yes, we would recommend the third dose of vaccine, specifically if people living with type 1 are over the age of 40 years of age, 40, are having not reaching the glycemic control, or actually having a bad glucose control. They don't want to have bad glucose control, but last A1C was really high, around 9%, or if they really have a significant complication of diabetes. And I believe there are a few questions also in the chat. I will try to see if there are things that I would have been. Thank you very much. We have a few of nice comments. David, I take you to speak to my kids. They always say I'm a dinosaur and I'm telling silly things on the most of the time. We really thank you for those good comments from that. And I'm just seeing sometimes we had some people with those things around mitochondrial metabolism and also things. Yes, there are things coming. This is a bit far from the patient. And thank you for all the nice comments in the chat. So we are very close to the end of it. Any last final questions? Otherwise, I really thank you for taking time in the evening to discuss with us. I have a lot of fun and pleasure to do this. And some of your questions, comments are really impacting the way we do research. Your comments is not only the question you express, it's really linking us to modify all of this, around of this. And thank you very much for the one that around this. I really appreciate that evening with you and that way to interact. COVID is a bad thing, but it had led us to go a bit more in those interaction, and we appreciate this. Good evening, bonne fin de soirée. Thank you very much. Merci beaucoup. Thank you, everyone.